help
Hello, good morning and welcome to today's presentation on preeclampsia with this case presentation. Now, a 28-year-old woman in her first pregnancy is admitted to the labor ward at 38 weeks of gestation. She has no past medical history of significance. Her blood pressure when pregnancy was first confirmed at 8 weeks was 120 and 70 millimeters per mercury. Today, she presents with a mild frontal headache and increasing swelling of her ankles. Now, her blood pressure is 170 over 120 millimeters per mercury. Urine dipstick testing shows 3 classes of protein, and there is also edema of both ankles to the mid-calf. Now, what is the most likely reason for these clinical signs? What other symptoms and signs should be looked out for? And also, what is the risk factor, or what are the risk factors for your diagnosis, and what investigations should you perform in these situations? We are going to look at the answers to all of these questions by the time we finish with this presentation. Now, the key points we need to look at over here is the woman is admitted at 38 weeks of gestation. Her blood pressure at 8 weeks of gestation was 120 over 70 millimeters per mercury. Now she is complaining of frontal headache and increasing swelling of her ankles. Blood pressure is 170 over 120 millimeters per mercury, which is very high. And also urine dipstick is testing 3 classes of protein. And there's also edema of both ankles to the midcalf. So straight away, per the topic of our discussion, preeclampsia is the most likely diagnosis. And it is interesting to know that preeclampsia is a multi-system disorder which occurs often after the 20th week of gestation, and it has various features, severity, and even its rate of progression differs from one woman to the other. Now, there are a number of definitions of hypertension in pregnancy which lack, consistency sometimes, and sometimes it's even confusing. And so, in essence, high blood pressure in pregnancy can be preeclampsia in the first place, pregnancy-induced hypertension, pre-existing hypertension or chronic hypertension, or even a chronic hypertension with superimposed preeclampsia. Now, what are the meanings of these terms? When we say preeclampsia, it is any blood pressure recording at least 140 over 90 millimeters per mercury on 2 separate occasions, at least 4 hours apart, and in the presence of at least 300 milligrams of protein in a 24-hour urine collection, which occurs usually after the 20th week of gestation in a previously normotensive patient or normotensive woman, meaning the woman didn't have hypertension before she got pregnant. And this usually will resolve completely by the 6th week, postpartum. Now, when we say pregnancy-induced hypertension, what we mean is this type of hypertension occurs as a new onset or any hypertension which develops for the first time in the 2nd trimester with no significant protein in urine or any of the features of preeclampsia such as headache, visual disturbances, or even epigastric pain. Now, with pre-existing hypertension, also known as chronic hypertension, what it means is this hypertension predates the pregnancy, and so the woman had hypertension before she got pregnant. And usually, the common cause of this type of hypertension is essential hypertension. And also, it is known that the causes of this form of hypertension is totally different from the causes of preeclampsia. And as such, we have other causes of this form of hypertension, such as renal diseases when the patient has glomerulonephritis, diabetic nephropathy, and also in renal artery stenosis. And some endocrine diseases such as pheochromocytoma, whereby there is excess or too much production of hormones such as epinephrine, norepinephrine, which regulates the heart rate as well as the blood pressure. And so there is constant elevation of blood pressure, and also in coarctation of the aorta, and in some cases some collagen vascular disease such as systemic lupus erythematosus may also cause may also cause pre-existing hypertension in these women. Now, these women can also have chronic hypertension with superimposed preeclampsia. It means they already had their hypertension before they got pregnant. However, during pregnancy, they started exhibiting signs of preeclampsia, such as protein in urine becomes evident, and also they begin to complain of headache and also the epigastric pain, blurry vision. So all these signs may be present in these patients, and when we find them, we say they are having chronic hypertension with superimposed preeclampsia. Now, what are the symptoms that we need to look out for, as well as the signs? Basically, these women will be complaining of headache, and the headache is usually due to cerebral edema. They also say they have visual disturbances, and it's usually due to reduced blood flow to the retina. And some of these patients may complain of seeing some flashes of light. And when it happens like this, it tells you this woman is having a severe form of preeclampsia. They may also complain of epigastric pain or right upper quadrant pain. And this is usually due to injury and swelling of the liver capsule. And this is one of the cardinal or the main symptoms of severe preeclampsia. And they may also have nausea and vomiting due to these hormonal differences, as well as increasing swelling of the legs and fingers, as well as the face due to disorder or altered function of the vessels, which makes the vessels have increased in their permeability, and so fluid leave the vessels into the tissues. Now, looking at the signs of these preeclampsia, we may see it in almost all the systems of the body, since we said it is a multi-system problem. So in the cardiovascular system, these men may have hypertension, and also they may vasoconstriction, which you may see when they have cold peripheries and also peripheral edema. In their respiratory system, they may have pulmonary edema, also facial and laryngeal edema, which may lead to acute respiratory distress syndrome. With dyspnea, they may have difficulties in breathing, and so forth. Now, with the renal system, they may have proteinuria, that is protein in urine. Also, the amount of urine produced will fall drastically. So they may have oliguria. They may also have acute renal failure. Now, we may also look at it or find out in the central nervous system hyperreflexia and clonus, as well as cerebral hemorrhage in these women, and they may even convulse. That is the eclamptic phase of this condition, and they may also have papilledema, as well as even go into coma. Now, these women may have other symptoms such as the HELP syndrome, and when we say HELP syndrome, the meaning is hemolysis, elevated liver enzymes, and low platelets. Now, this comes as a result of the fact that in the liver, there is going to be fibrin deposition in the subendothelium. And this usually is associated with elevation of the liver enzymes. And this may also be associated with hemolysis and low platelets, since all the clotting factors will be used up. Now, about 10 to 20% of women with severe preeclampsia or even eclampsia will get HELP syndrome. Now, let's look at how all of these happen one after the other. Now, since there is going to be endothelial cell injury, it will lead to the formation of more thrombi in the vessels. And this is a process which uses or which uses up a lot of platelets. And so in the first place, there's going to be what? Low platelets. And as the red blood cells also moves along and they encounter or they meet these thrombi or the stationary clots in the vessel, they end up getting destroyed, and so there will be hemolysis. Now, these come together to form the HELP. So we already have elevation in the liver enzymes. We have the low platelet, as well as we have what do you call it, hemolysis. Once again, the injury to the endothelium will increase the vessel permeability, as I alluded before, and this allows fluid to seep out of the vessels into the tissues, and this is worsened when there is loss of protein in urine, and also we realize that more fluid move into the tissues, leading to generalized edema of the face, the hands, as well as the legs of these women. And this is also part of the reason why they have pulmonary edema. And so they begin to have shortness of breath and also cough, and they begin to have cerebral edema. And it is this cerebral edema which usually causes the headaches, confusion, and may even lead to seizures, as we see in eclampsia. Now, fetal signs that we may also see may include the abnormalities of cardiotocography, whereby these fetus will exhibit signs of severe fetal distress. There may also be preterm labor and also intrauterine growth retardation. Now, what are the risk factors to this particular condition? Now, we talk about premiparous women as being at high risk of developing preeclampsia. Now, it is believed that the mother receives both fetal and paternal genome protection through the normal fetal-maternal transfusion during pregnancy, and also especially during delivery. And so these women stands very little to no risk of developing preeclampsia, and also in subsequent pregnancies. It is also believed that prolonged exposure to the partners or paternal antigens through unprotected sex also reduce the chance of getting preeclampsia in subsequent pregnancies. However, there is the notion, or there is this belief, that if she gives birth with a new partner, she still stands the chance of getting preeclampsia as it's her first pregnancy. So with your former, or if you give birth continuously with one partner, that you stand little chance of getting preeclampsia. But if you change partner, it looks as if it is the first time you are giving birth, and so you stand the high chance of getting preeclampsia. Sometimes also maternal genetic predisposition also exposes them to preeclampsia, and we also have it being common about twofold, even fourfold, if the patient has a first line family relative who has had such a case before, and it even increases sevenfold if preeclampsia complicated these patients or these women's previous pregnancy. Now, multiple gestation has also been complicated in the risk factors of preeclampsia, and also we have other comorbidities such as advanced maternal age, obesity, and also diabetes mellitus, all being complicated in this preeclampsia. And the increased prevalence of chronic hypertension and other comorbid medical illness in women more than 35 years explains the increased frequency of preeclampsia among these women. Now, what investigations should we look out for? We must look out for proteinuria in the urine, and we may find out when we have 1+ dipstick of protein in urine, which may indicate 0.3 grams per liter. Then if it shows 3+, or 3 pluses, it may mean this woman is having 3 grams of protein in urine. We can also use a 24-hour urine collection to determine the amount of protein in urine, and also the protein creatinine ratio, which is more than 30, may also be significant to determine that protein is in urine. Now, we may also need to assess the urine output to look out for oliguria. Now, in the blood, when we take the full blood count, we may have low platelets. And if there is low platelets, it may be pointing towards thrombocytopenia as well as HELLP syndrome and even DIC in these women. And if the woman is having a pneumocytic anemia together with schistocytes, then it indicates that this woman may be having hemolytic anemia or even HELLP syndrome, as we've seen earlier on. On coagulation profile, prothrombin time as well as partial thromboplastin time may be elevated, which will tell us that this woman may be getting DIC. Now, when we have decreased fibrinogen level, it will also point to DIC, and an elevated uric acid level will also be pointing that there is problems with the renal system. And also, as we've seen, elevated liver enzymes, when we find this out in liver function test, may point to the fact that this woman may be having HELLP syndrome. We may also test magnesium and also serum levels of this woman. Now, other tests that we can do is the regular assessment of the fetal well-being using the cardiac tachography, as well as using the ultrasound to measure the fetal size and also the amniotic fluid volume, since we said there's going to be small fodate in these women. We can also assess the blood flow to the placenta using the Doppler. Now, we may also do amniocentesis. And in amniocentesis, it will help us to assess the maturity of the fetal lung. And when we have a lecithin sphingomyelin ratio, which is more than 2.0 to 2.5, which is normal, it's an indication that there will be absence of respiratory distress syndrome in this fetus. However, any lecithin sphingomyelin ratio, which is less than 2.0, will suggest that there is imminent fetal respiratory distress syndrome, and all people who are involved to help in resuscitation of this fetus should be called. Now, what criteria must we use in diagnosing preeclampsia? Now, the first thing is there must be the blood pressure must be more than or equal to 140 over 90 millimeters per mercury, or if there is a blood pressure which measures 160 over 110 millimeters per mercury once, or which is confirmed within minutes. Now, there must also be proteinuria, which is more than 300 milligram per 24 hours urine collection, or proteinuria creatinine ratio, which is more than or equal to 0.3. This must be the criteria for diagnosing preeclampsia. Now, in the absence of proteinuria, a new onset hypertension with new onset of any of the following, such as thrombocytopenia, whereby the platelets count is less than 100,000, renal insufficiency, whereby serum creatinine is more than 1.1 milligram per deciliter, and also in impaired liver function, whereby the liver enzymes, or there is elevated liver enzymes of AST and ALT 2 times more than the normal levels, as well as the patient complaint of pulmonary edema and also cerebral or visual impairment. We can use this to diagnose the presence of preeclampsia in these patients. So this will bring us to the end of this lecture. In our subsequent videos, we are going to look at how to manage this woman, and when other complications set in, how to deal with it. Thank you very much for listening to me.